on Grieves.
Thank you very much. Okay, so graveyard shift starts now. I've got the dubious task of filling in for Professor Mike Chester, who couldn't make it at the 11th hour, 59th minute. So I've got the easy task of presenting his slides in front of an audience, so it's not a problem, is it? So wish me luck. I actually know what I'm talking about, so that's another thing. Okay. Quick show of hands. How many GPs we got in the audience? Okay, how many practice managers? Whoa! 3 to 1. How many other? And how many lost geologists from the other hole? None. Okay, good. So we've got a pretty good mix there. That's good. Okay, so we're going to go hopping across the stones across the stream here, really hot-footed. We're going to give you a little insight into patient-centeredness. We're going to give you a few hints and tips about what you might want to try back at your practice. My background, very quickly, is I'm from the multinationals. I've been working with multinationals all around the world for 25 years. I know what you're thinking. He couldn't be. He's looking so young. But actually, I have 25 years, and I'm a granddad with a 2-year-old granddaughter. And I'm working with Professor Mike Chester, and we're merging the best of Mike's experience over the last 10 years in the NHS on patient-centeredness, and my experience from the multinationals in different organisations, bringing in all these tools and tips and techniques with a people focus, with a culture change focus. And my goodness, is it powerful when the two come together. So let's share some ideas with you. First things first, I'm sorry I have to do this. Safety comes first. And the reason I do this is because I was actually there when that happened. Hands up all those who remember where they were when that happened. Absolutely. And you've all got a story to tell. I was actually on the George Washington Bridge when the plane flew over. And we had people in the building, and we had some friends in the building who got out, thankfully. But I'm a stickler for fire exits, because some of the fire exits were blocked on that day, so they could have saved more lives. So let me tell you, there are no planned fire alarms. That exit and that exit, we both go around to the right, and there's an exit there which takes you into the car park as a muster point, okay? And I really mean that. Practice makes perfect, yeah? This is not just going through the motions. I took that picture in Liberty Park a week before it happened with my 3 kids, and you can see that just the tops of the Twin Towers behind me. So always there in my heart and in my head, practice what you preach. Okay, you've probably seen this before, the Secretary of State white paper. Basically, we're talking about no decision about me without me. So this is now getting into the realms of the patient. What that doesn't mean is we tick this box off by just doing a survey and having a patient group. They're important, but you need much more than that. This is not a box-ticking exercise. If you're going to engage your patients, you have to treat them like customers going into a 5-star hotel, and it's the entire journey that you're looking at. I did a workshop for about 50 GPs last Thursday, and I asked them to go through the patient experience. And they obviously said, what are you talking about, John? I said, well, look, my daughter, Millie, who's 22, you wouldn't believe that from the last picture, 22, oh my goodness. Where does the time go? She was sitting on the couch watching Britain's Got Talent the other day, and she said, Dad, I've got a pain in my arm. I said, all right, okay. She said, I don't know what it is. And immediately she Googled it on her iPad. And she said, right, I'm going to have a look at this. I'll probably ring up to go see the doctor tomorrow, but I'm going to look at it first. I said, oh, good one. Well done, Millie. By the way, I wasn't watching Britain's Got Talent. She was watching it, although I did have a sneak preview. And this just sort of demonstrated for me a little journey that I wanted to give to these GPs last week. And I said, I want you to walk through from my Millie's twinge in her arm through the whole process of getting in contact, getting appointments, going through the front desk, actually seeing you, getting the drugs, coming out, recommendations, coming back again. I want you to walk through, for the next half an hour in your head, your patient journey. And they all looked at me as if I was mad. We know that. What's the point of doing this exercise? Just humour me. Do it. So we had 50-odd doctors doing this exercise in groups of their GP practices, and what came out was amazing. Because they were actually walking through with patient eyes every single part of the process, from Millie's twinge, watching Britain's Got Talent, to the final cure. And there were so many ideas that came out of that, simple ideas that they were going to take back to their practice. Stupid ideas like putting a sign in the right place, not getting patients trapped in a cupboard, which some people did, walk the wrong way. Very, very simple ideas. And this whole process about patient engagement is based on very simple ideas. But listening to patients, listening to staff, listening to carers, listening to everybody as part of the team. So I just wanted to mention that. No decision about me without me is not about let's do a survey once a year and let's have a patient group. That in itself is a double barrel gun. That's a double-edged sword. Because if you're engaged with a patient group, fantastic. But if you have a patient group and you fall out with them, oh my goodness, watch this space. So it's a loaded gun. You've got to be careful with that one. So a bit of research done on the King's Fund recently, and you can see some of the revelations here, which you all know about. We're basically going to have, I'm stooping here, so I'm going to have a stooped neck in about 5 minutes, isn't I? We're having an ageing population, no surprise. Patients expect more, and they expect more of a responsive service from whoever they talk to, and they also expect integrated service as well. They like to talk to the same people, but if you have to hand them across to other care providers, they want a seamless link. It's like a seamless supply chain. And patients and carers want to play much more active role in decision making. So like Millie did, she immediately Googled it, and she came up with her own ideas. And we were talking about it before. People are walking into practices now with a 3-page printout of what their deal is for their disease. And they're going to tell the doctor, this is what I've got. They didn't do that 10 years ago. So we've got to be ahead of the curve here. We've got to anticipate this. Interestingly enough, what came out from Millie's research was she had carpal tunnel syndrome. Which is not quite the right, but anyway, at least she tried. So what we're basically saying here is we do have to get ahead of the curve here, because the patient profile is changing and the patient expectations are changing. Now, I know the doctor's interaction with the patient is critical. And if Mike was here, he would be telling you passionately that he's been really working in this area to develop the relationship with the patient to the point where he's into the hearts and minds of his patient group, and they absolutely love him, and they're working as a team. So that interaction between the patient and the doctor, very important, but that's just one piece of the jigsaw. If you think about walking into your doctor's surgery, once you get past all the signage and the car park issues, you don't have to put your hands up on this, but quite often, the first person you come across is the dragon at the front desk who's snarling and spitting at you because she or he doesn't want to talk to you. Now, every practice has got one. You might have 6 or 7. And I've done my own surveys, and they do exist. And burying our head under the welcome mat is not going to get rid of it. And if you did a patient satisfaction survey, the doctor's interaction might have been fantastic with the patient, brilliant, but they might have marked it down because of the front desk, or because of the rudeness on the telephone, or because of the fact that the toilets were dirty. So the whole thing is about the patient journey. It's about the patient experience, like in a 5-star hotel. So get the picture? It's not just about the interaction with the doctor, although that is very important. Okay, let's keep track here, because we're very tight for time. So these are some of the issues, again, still coming from the research from the King's Fund about the engagement and involvement of patients. Basically, the bottom line is that we have to be ahead of the curve. We've got to be more responsive to the patient's needs. As the age profile gets older and older, you're going to have more complex needs. So you're going to need more parts of the care process. So it's not just going to be one interaction with the doctor. Interestingly enough, Mike would say at this point, it's very difficult to get a good quality discussion with a patient. You know, everyone's rushed for time, 5-10 minutes, maybe 15 minutes, and I know the QAF have come up with some guidelines as well. Mike tore that book up, and he gave 45 minutes to his topmost resource-intensive patients, which is unheard of. And it goes against the grain that. How could you do that? That's impossible. Actually, he broke the negative mindset. He broke the negative spiral. That 45-minute investment with the patient made the patient feel so good about themselves and so interested and building the trust like they've never built before with a doctor, that they were actually starting to listen to advice. They were actually starting to take some drugs like they were supposed to, almost on time. And if you fast forward that for a whole year, okay, he had one 45-minute chat with this person who was coming in regularly for 20 minutes, about 8 times. The total reduction in time was massive. The savings were huge. And we'll go through that. I've got some graphs to support that. So this is a little bit more about the fact that an untapped resource in the NHS is in fact the patient. And if you can get the hearts and minds of the patient, boy, can you move mountains. So, how do we create the optimal conditions? As I said, you've got to look at the whole picture. It's not just aspects of it. Although, as I say, the patient-doctor interaction is very important. But you do have to look at the whole aspect of it. Here's a slide that I've imported from business, from industry. I've worked for Unilever for 17 years, as well as a lot of other multinationals, 25 years altogether. My lead role in Unilever was like a change agent and continuous improvement director. And I was based in, of all places, Saudi Arabia for 3 years. Wow. Talk about a culture shock there. Whew. An even bigger culture shock, I spent 3 years in America as well, separated by a common language. I'll tell you what, it was a bigger culture shock to live in America than it was to live in Saudi Arabia. How weird is that? Think differently, act differently, behavior differently. But this chart I knocked up because it's to do with culture change and getting into the hearts and minds. And if you get the right vision of your practice or what you're trying to do, you've got the right commitment from the resources, the steering committee, the sponsorship, you've got the right resources and the right number to do what you want to do, and you've got the right skills level. I'll give you a quick example of that. There is no magic formula to this, apart from attention to detail and passion. And silly little things like, I'm doing some work in a London hospital at the moment on patient discharges, smoothing out the patient discharge process and sprinkling some magic powder on that to make it work. Not a real issue there when you're trying to coordinate 10 different departments and each one's blaming each other. Not an issue, but we'll get there. One of the tiny little issues that was not even on the radar scope was the fact that some of the nurses couldn't use an email. And of course they're going to be embarrassed about that, obviously, because they feel as if they want to be keeping up with the 20th century and they want to be using email. So because they haven't used email, they haven't been trained in it and they're a bit embarrassed to raise the issue, they're using fax machines. And the faxes break down and they run out of print and ink, and all of a sudden you've wasted 1 hour on a fax machine in 2013. So the skill levels are very important. And it only takes somebody to say, do you know what, we're going to give you 2 hours on how to send an email. Not a problem. Don't feel embarrassed. Let's move on. Let's progress. This is not blame culture. This is not finger pointing. It's about giving a smile to Mrs. Miggins, who's the patient that's waiting to leave her bed. So any issue that comes to stop that happening, we want to deal with it, and it's not personalised. We want to move on. So you've got to have the right skill levels in place. And you've got to have a plan to do it as well. So if you have all those things in place, perfect. And I've tested this for decades in many different companies, and it works. And listening to people who've talked about vision without action is merely a dream. So if you've got an idea, but you do nothing about it, then you're just daydreaming. Action without vision is merely passing time. So you're busy, and boy, some of us are busy, running around in circles doing not much really to get us to that vision. But action with vision can change the world. Who said that? Apart from me. Who said that? Graveyard shift kicking in. Okay, I'm going to help you out here. This little fella. Quite topical, actually. I asked somebody else at a session, which I did, and I used the same slide. I said, who said that? And somebody put their hand up very proudly and said, yep, I know that. It's Beyonce. Okay, fair enough. She probably did, but I can't back it up. But anyway, so a successful change formula, have those things in place, and you will start to etch away at culture change. And we do need a mindset shift. We do need a culture change to anticipate the needs of the patients going forward. In some cases, patients are very educated in their ailments. And we're talking from children to over 100 years of age, so we've got to be ready for this. So here's a little graph that I've also imported. Each practice, each area, each hospital does have teams that come together and we do make improvements. Fantastic. So you see the graph going up, we're making an improvement, but guess what? After the bandwagon leaves town and everybody takes the focus of what it is you're trying to achieve, it goes straight back down. And this is classic sawtooth improvement. Basically, you don't improve. I'd rather not do any of that improvement. I'd rather have a straight line, because that is demoralising for the staff. It's demoralising. Can you imagine the patients if they come up with a suggestion? Great, we've implemented it. 3 months later, it's not only back to square one, but it's worse than it was to start with. What kind of a message is that to the patients? What kind of message is that to the staff? Nobody's caring. Nobody's chipping in. So we need to keep that focus. And the easy bit is making the improvement. The hard bit is maintaining it. And then the harder bit is to going up again. So it's like a step change. So it requires a different mindset. And this is typical of the Western approach. We've got 40% daily operations, doing stuff, and 60% firefighting. 60% repairing problems, looking out for lost records, wrong information, missing drugs, you name it, it's in the system. And hand on heart, I know this because I've been there and I've done it and I've been part of it myself. The Japanese approach and the Eastern approach is very much, yes, you've got to do your normal work. There will still be some firefighting because we're not perfect, but a massive amount of this is about continuous improvement. You have to look at how to improve every aspect and every angle and not ignore a suggestion or an improvement. I couldn't help it. As I'm walking around here, I saw a couple of bits of paper on the walkway on the red path, and I just had to pick it up. And I saw so many people stepping over it going, well, that's not my problem. I'm not interested. I'm not going to pick it up. Or he just didn't even see it. I can't do that. I'm so passionate about improving the workplace and the patient journey. I have to pick these things up to make it better for somebody to walk past on the path. So that's a little bit about the different mindset. And it's hard. To start with, it's hard. I interviewed about 35 people in a London hospital a couple of weeks ago on this patient discharge project. Every single one of them at some stage said, John, I'm in a hurry, and looked at their watch. Every single one. Every one of the 35 people. That, to me, is a measure of organised chaos. Everyone is looking at I haven't got time. You haven't got time what? Because I've got to get back because somebody didn't turn up to the meeting, or we've got a 4-hour blockbuster meeting where it's only 10 minutes of value, but I've got to attend for the 4 hours. Or I've lost a record. Or, there's issues in there which could really make you challenge it to say, really? Really? Is every one of the 35 people I've interviewed from all different levels and different departments all in the same hurry? Is it that chaotic? Could well be. But we have to break out of that mindset, and somebody has to be bold enough to step forward and start doing something differently. And I know that's very difficult under the present circumstances where we've got initiative overload, like a tennis gun that's banging out initiatives from Whitehall every 5 minutes. I understand that. But we've it was no different in industry when the chairman and the main board were banging out initiatives because the shareholder was demanding that the share price needs to go up, so we've got to make improvements at left, right, and centre. We've been there and done it, and you can get through it. We have a red light. Okay. So, at that point, I shall... is that the 20 minutes? 5 minutes. Okay, 5 minutes. I got 5 minutes. The 5-minute warning. Excellent. So we haven't got 5 hours. It's only, okay, fair enough.
I'm trying to get the other people switched off as well, but that's not...
Shut the lights down and lock the door. What I want to do now is I want to whiz through and show you some of the graphs from Mike that backs up his approach of total user engagement. Mike did this 10 years ago. That's his zeitgeist in the NHS. I'm going to flick through some of these. Here we go. Some of these graphs. Mike set up the NRAC, the National Refractory Angina Centre, back in 2000, where he used these approaches and really got into the hearts and minds of his patients. He won the Nye Bevan Award. His team won the Doctor of the Year Award. The accolades are tremendous, and the results are astounding. But even then, when he had such a high rate of percentage customer satisfaction, patient satisfaction, because they weren't auditing, they were starting to drop. Because they weren't checking, you remember that sawtooth? Because they didn't have things in place to stop it coming back, they started to regress to the mean. So even though he was 99 point whatever, it was coming back 98, 97. And he said, you're absolutely right, John, we needed systems in place, even though we were good, to stop us going back. So that's that graph. That's his award. These are some of the results of monthly cardiac days in hospital before his patients came onto his NRAC enrolment, the total user engagement approach, and after. And really, there are some stunning savings here. And it's not just about savings, but it's about the patient satisfaction, it's about the savings, it's about the quality. 70% savings, which was about £1.5 million. These are heart attacks before and after he got his claws into the hearts and minds of his patients. So then they enrolled on the programme, and the heart attacks per patient dropped drastically. Saved over £50,000. Patient centre continuous improvement. Yeah, I want to show you the graph. They're all the bragging accolades. You can read that on the internet. Net savings in primary care. 221 patients, no complaints. Net savings about £1,000 per patient. And you can read the rest. The quality of life increased from 55 to 77. And these are backed up figures, and he's tested them not just in his clinic but in other clinics, Chesterfield, Wirral, and it really does work. But you've got to work hard to start with it to get it off the ground, and it's not easy. He used the Picker Institute. The Picker Institute did a 1 to 10 rating. He basically was doing that 10 years ago, using a 1 to 100, asking the patient every single time, what can we do different? How can we make it better? I know we're 99.5. How can we make it 99.9 and 100? And a few tools that we're using now, and Mike's using this he's a member of 3 CCGs. We're using simple little tools called a 1-point lesson. And it's literally just a 1-sheet, 1-point lesson, one idea, one improvement, one suggestion to make it better for the patient in the CCG leadership team meetings. And we've asked them to rate the meeting itself, and I know what meetings are like, it's the bane of my life, but you need to have meetings to coordinate. We ask the groups how patient-centred was this CCG leadership team meeting. And then they open it up to the public gallery and they get them to vote as well. And they're listening to the discussions around the table. And it really is, it's tough stuff, and it's quite bold, but they're opening up their front court and saying, we want your input. And so they keep a track of all the issues on how they run the meeting. And patient-centeredness is one of them. On that note, I'm getting the eyes, so I shall stop and say thank you very much.
Yeah, thank you very much, John. Can we give John a round of applause, please? His passion for his subject exudes from him, if you don't mind me saying so, John.
That's sweat.
What we're going to go straight down and let this go to the floor, and we have a question already, because this is a very important subject, I think, for us, especially bearing in mind the challenges we face over the next few years. So if I could have the microphone, please. Gentleman here, 4 rows down.
And can we also bring
Just
Navin
your
at this
left.
point? Yeah, okay.
You said you put the system in place. What happens, when the patient rings the receptionist and the receptionist say, I'm sorry, the doctor is too busy, there's no appointment. At the other end, there might be not a nice language, number one. And number two, when they come for repeat prescription, oh, can I have the repeat prescription? All the notice board is there. Now what the poor receptionist has to say and what sort of advice you would tell us to put in action and plan to avoid these circumstances?
It's a really interesting point, that, and it came up in the GP workshop last week as well. Can I just have a quick show of hands? Hands up those who think there is an issue with booking appointments. That's exactly what came up. This is a UK-wide problem. This is not individual GP practice. This is a UK-wide problem, and I think this needs to be taken at a strategic level, because this is holding back some good continuous improvement. Some of the GP practices have tried other things and they've made moderate improvements in it, but it's not cracking the core root cause here. So we're not going to solve that one today, and I think that needs to be taken back to senior levels, because it's having a major impact on progress and patient satisfaction. Now, do you want to add anything to that, guys?
Yeah, I mean, I wonder if I could just. So I'm Nav Chana, by the way. I'm a GP. I have a GP practice in Southwest London, and I'm a vice chairman of the NAPC, which is why I'm here. And I think there's the issues around improving engagement with patients go back from a long way beyond the practice, really. So there's some very interesting work that's come out of Canada. From the Ivy Institute of Health+Care Innovation, which says effectively that patients within a population want 3 things. One, that they want care across a continuum. They want all the providers of healthcare that look after them to kind of be aligned, so their journey is kind of relatively coordinated. Secondly, they want tools that help them look after themselves better. And one of the questions that popped into my head as you were talking about repeat prescriptions is, arguably, we may not have designed our system so that actually patients can access their repeat prescriptions in a different way, rather than having to physically walk into the practice and do something. And the third thing that patients want is some tools to help them improve their well-being. So keeping them fit, keeping them healthy. And I think our primary care system probably needs to change a little bit to address those issues if we genuinely want to be engaging with our patients and our populations.
Thank you. Can I chip in perhaps a contribution from my experience of the kind of scenario that you've just described? I worked with about 25 practices over the course of the past 3 years on patient participation, and this is one of the things that crops up the most. The difficulties that our receptionists have when they are having to deal with extremely difficult patients. And my answer to it is simple. What we need to do is to make sure that our reception colleagues are properly trained in handling people who are being difficult. And that's the only way forward, because in general, we live in a world which is becoming increasingly self-centered and increasingly egocentric. People scream at you if you cut them up on the dual carriageway or whatever it may be. It's all about me, and if I can't get at what I want, I'm going to swear at you, basically. I'm going to make life difficult. And with all due respect, our receptionists are human beings as well, and it tends to get wrapped up. Training is the answer in dealing with difficult people. Ladies and gentlemen, do we have any more questions? Any more questions? No? Ladies and gentlemen, can I ask you to show your appreciation to our two speakers this afternoon for their input, and I hope you've enjoyed and got something positive out of this session. Thank you very much, gentlemen.
Thank you.